Good morning. I just wanted to give you a very brief update on some of the policy issues and supporting activities that are live for Public Health England at the moment. And when I've done some kind of vague policy fluff, then my colleague Viv Hope gets to do some real science with it. I'm sure you all know that the old National Treatment Agency has been abolished and its functions subsumed into Public Health England. All of the previous kind of central functions have gone into the Health and Wellbeing Directorate, which is where I sit. And there we sit alongside what in public health terms are other health improvement agendas that take a life course approach to health inequalities. Sounds great. But we're working with other parts of what is now Public Health England, including people like Viv in what was the Health Protection Agency and now Health Protection in PHE. One of the other little changes for the central team is it looks like we might be able to get our hands on Frank, which is something we're quite looking forward to. The other drugs functions that were at the NTA have been distributed around PHE, which has some downsides and some possible opportunities. All the old regional teams are now just based in 8 of the PHE centres around the country, and they're part of the Operations Directorate. So we can no longer tell them what to do in the same way that they can no longer tell what we're DATs to do. It's much more, everything's about localism. It's just about us providing the advice, the support, the information, the data to help people do their jobs better. But there is what they call a kind of dotted line back from the centres to the national team. So we have a kind of a clear line of sight of what they're doing, and we're still working very closely with them. And the only other change is the national data development bit. The NDTMS development team has gone into the Chief Knowledge Officers Directorate, so we kind of lost a bit of a handle on that. Although again, as I say, there are opportunities as well, because they're now thinking much bigger and more broadly about some of the wider, say, mortality data that we might be able to bring into the organisation and tie into things like NDTMS. So part of the point of that is that now harm reduction and public health interests, they align in a way that probably wasn't the case when the National Treatment Agency had to be seen to be delivering the government's recovery-focused strategy. So you will hear more harm reduction speak, I hope, from PHE, and you'll see more clear harm reduction activity. I mean, a lot of it was still going on in the NTA. We just had to keep quiet about it. So some of the current harm reduction priorities and activities. Firstly, we've convened a new national intelligence network on the health harms associated with drug use. We're mostly focused on kind of the big providers and the Royal Colleges and some of the other umbrella groups coming together to share intelligence on maybe new patterns of drug use and how drugs are being used, and then to hopefully get that intelligence back out into services where they can actually make use of it. That had its first meeting in June, and on the back of each meeting, the idea is to then produce a briefing that goes out across the country to directors of public health, commissioners, providers. And the second meeting will be in October, focusing on kind of alcohol use in drug users, some issues around early warnings and alert systems for drugs, and what I mentioned about the mortality data is going to be talking particularly about how drug-related deaths are monitored, or in some cases inadequately monitored. The stuff on early warning at that meeting is partly related to an activity that we have for this year to improve some of the early warning systems. And there's a whole load of different formal and informal systems across government for pulling in information and then, as deemed necessary, passing it back out to areas. And a lot of it's designed to support the Home Office in banning stuff, which isn't really where our interest lies. So we're hoping to improve some of the systems that actually help get harm reduction information back out to the field. And that kind of works from the local level up to the centres to national, and also through the focal point, which we've now got in PHE, into Europe as well. And a lot of that early warning information relates to some of the newer psychoactive substances. Anyone who has any dealings with the with NDTMS, we'll know that we've added a whole batch of new codes for recording some of the NPS, not by drug, because that just wasn't going to be feasible, but by activity, by action, how they work on people. And we think that the injecting of some of the new psychoactive substances is posing something of a problem, and that's something that Viv will talk a bit more about. We're also concerned about men who have sex with men and some unsafe sexual practice that seems to be related to drug use. And there's a stakeholder meeting later this month. We're working quite closely with the sexual health bit of PHE, which is one of the bits that has come into the same directorate that we're in and is one of the opportunities for improved working together. And in relation to hepatitis C, there's a programme of work to look at how we can improve access to treatment, partly by collecting some examples of good practice that's already going on out there and then just reflecting that back out to the world. And improving some of the drug-related deaths and blood-borne virus guidance that we produce. In the past, you might have seen there was a kind of annex to the treatment planning guidance that went into a lot of detail about what local areas could do on DRDs and BPVs. And the treatment planning guidance has gone the way of a lot of things that the NTA used to be able to tell people how to do. But we have a series of recovery resources on a recovery resources dedicated website which can provide information and advice to the field, and that's going to be added to with some DRD and BBV specific advice. And the recovery resources, I mean, the old treatment planning stuff tended to get very long and detailed and a bit tedious. The recovery resources series, it's very brief, it's very practical, and it's all about concrete local examples. And then the only other thing I wanted to mention, there's a kind of what we've ended up calling the foil Nexus Nexus. So you know that there is a needle exchange monitoring system, and there's been a long-standing problem with it, in that it's underused by a lot of services out there, and it's been under-supported by us at the centre. And there's all sorts of complicated reasons for that. But for a long time, we've wanted to review how unstructured interventions, and not just needle exchange, but anything that isn't already recorded in NDTMS, can be recorded so that we can demonstrate the value of the investment that's going into it. So there's going to be a wholesale review of Nexus and what used to be called Tier 2 monitoring. I hope you're not recording that. I'm not allowed to say that anymore.
You want me to take that out?
Take 2.
But you all understand it, don't you? What used to be Tier 2. But that's going to be quite a long-term process, because it is potentially building, if it's agreed, a whole new national monitoring system. So in the meantime, we've had the Home Office come to us and say, there are the foil changes, which I'm sure you all know very well. Yeah, good, I'm not going to tell you about those. But the Home Secretary expects that the Home Office can monitor and evaluate the implementation of the foil according to the conditionality that she set on it. Now, the Home Office is actually they're quite realistic about the problems with that, and they just need to be able to collect a kind of a portfolio of data that goes some way to showing what's happened as a result of the change in the legislation. And they'll be doing some qualitative work with a sample of services, but they were particularly keen that if there was a way of using the existing national system, inadequate though it is, to collect information on foil given out and the people it's given out to, the number of people it's given out to, then they'd be very happy with that. So we've agreed that Nexus will likely be extended with just a couple of extra fields to collect information on those two things. Now, in part, we're hoping that will encourage greater use of Nexus. Now, I think probably a couple of extra fields on Nexus isn't enough for you to abandon your own excellent local systems and start using the not entirely adequate national system. But one of the other things we're looking at that we think might encourage you to use it is if, rather than having to re-enter the data from your local systems into the national system, there's a way of us sucking the data out of your local systems in the way that we do for MDTMS. So we're looking at what is that, kind of a back-end data piping system. So we can take the information out of your needle exchange systems and put it into the national system, if you're agreeable to that. But as I say, it's a way of us hopefully getting the foil data keep the Home Secretary happy. But I'd be quite interested in what you think about the whole foil issue, the monitoring of it, the extension to Nexus. Please find me during the day and tell me what you think, good or bad.
Right. Thank you very much.
Thanks.
Thank you.